Okay, we'll call this meeting to order. A bit of a change of, I'm sorry. Um, First of all, we'll have roll call by Rhonda. If we could, please.
Yes. If I can remind everyone to please pull your microphone closer so that way they can hear you talking also. Uh, Jeff DePass,
Present.
Dr. Turner,
Present.
Brian Garcia,
Present.
Dr. Lim,
Present.
Dr. Caddick,
Present.
Dr. Ross,
Present.
Dr. Ruckin.
Present.
It's loud.
Very good. We followed the same meeting structure, Joni, for this point? Okay.
Yes, please.
Very good. Okay, we'll move on to the first action item, which is to approve the minutes from the July 15th meeting. Is there any questions about that meeting, or do we have a motion to approve for that?
Motion to approve.
Second. Okay, motion's been approved for the minutes of July 15th meeting.
The financial report is the last page. Okay, all approved?
Aye.
Thank you. Sorry about that. Financial report. It's the last page. You're going to see on the health immunization grant, the top one is the one we're working on right now. The bottom one was from the previous ending year. Why there's 20913, I'm not sure, but that's how we've ended up. So you'll also see the COVID-19 claims that we've had so far. I haven't added some that are in another file folder that I've got. And then also we have a health cares grant, which Joni may discuss later. That will appear also.
So we had a $250,000 grant to pay for tracers, is that?
No, it's part of the CARES Act that the county received
Okay.
to cover expenses, whatever those expenses are for any department, or whatever expenses have been incurred by any department, whether it means the plexiglass that's out here, but this is specific to our department.
So is it enough?
Yes, that's just how much we've spent so far. It's not the amount that we've been allocated. The allocation actually came to the county itself.
So there's plenty in reserve for this particular.
Yes, there is. And then the $300,000 is $150,000, one to go contracted with regional and union, and that's to stand up testing sites all the way until June the 30th of 2021.
So the 300,000 is used up already, or that's
No.
still sitting there? Okay.
The $30,000 is a contract with union and regional, where they will bill us each month for the services rendered for standing up the clinics, the testing sites at union and at regional between now and June the 30th.
Budgeted out over the course.
Yes.
Yeah.
Very good, Ron. Is there any other items for our financial report? Any questions on the financial report? Okay, very good. Dr. Brucken, Health Officer's report.
Yeah, thank you. I want to start this just as I think I did the last time, just to say thank you. Everybody that's out here. So it's been excuse me, it's been a trying time. Obviously, I'm still working right now, so if my phone goes off, ignore that. I did wear COVID-free scrubs. I changed before I came for everybody. So, you know, obviously a lot of media attention right now about the hospitals filling up and all those things. So everybody's been busy. The hospitals are incredibly busy. The doctors are busy. The healthcare providers are busy. These contact tracers, everybody doing double and triple duty out here. So certainly hats are off to the work that's being done. So, you know, just forever grateful for the effort put forth. Outside of that, you know, obviously everything is COVID 100% of the time right now. Trying to keep up with everything from the medical side of it to public health, and and interacting with everybody every single day. And I know you guys are, we certainly appreciate the support from the board and everything that's going on here at the department. So outside of that, I won't belabor any other things. Certainly happy at any time to field questions about life in general right now. If anybody has any, feel free. So otherwise, we can move forward.
Very good. Thank you, Dr. Bruckett. Next, we'll move on to new business. The first action item is the health officer's reappointment, Dr. Bruckett. We need to have a vote, obviously, on this. All in favor to keeping Dr. Bruckett in as the health officer's reappointment?
Aye.
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 All opposed? Very good. I want to thank you, Dr. Bruckner, for everything that you do every day to keep everything consistent and professional. And we are glad that you're here.
Thank you for the thank you for the vote of confidence, for sure.
Dr. Bracken,
Sir.
just I know I hope I'm within the ask you some questions on the COVID thing. The cases is up, way up, right? How many cases are there, Johnny?
Over 5,000.
5,000.
Mhm.
So in our experience, how much is hospitalization rate and death rate out of that number of things?
Mhm.
Are we at par with the state, or are we below in our death rate, or are we above, or do you have a snapshot of that?
Yeah, and when we chase these metrics down, Dr. Lim, it's very difficult. Everything is population based, and you've seen the color coded county maps and things like that, where it's based on 100,000 population. So we're orange, which is one step away from being red. Our community numbers continue to go up exponentially. We're seeing that from gatherings. We're seeing that from a variety of different places. Our two hospitals are busier now with COVID patients than we definitely were earlier on. We are holding patients in the emergency room waiting on beds at times at both hospitals. We have more patients ventilated currently with COVID-19 than we did early on in this. And when the big surge to help dampen that curve was pushed out there earlier, it was to prevent the onslaught from overwhelming healthcare delivery. Everybody got behind it. You saw all of the celebrities, we're all in this together. Well, that has gone away. And you can't even call it a second wave because the first wave never really developed. So this is the first wave hitting through us. Between the two hospitals, we have about 100 patients hospitalized with COVID-19 right now. Probably well into the 24 range in the intensive care unit. Many of those ventilated. We had a unfortunate death today of a very young person, only 41 years old, not a county resident. And you'll hear a little bit later too, when a patient expires within our county, within our hospital, but they don't live here, then they don't get attributed to our death toll that people see on the news. So our 42 does not change to 43. Some other counties, such as Putnam County, might change from 13 to 14. So the deaths in our county and our hospitals that are tracked by the news and by the state, those are in the end, those are Vigo County residents. And if they die in Indianapolis, then our number goes up one.
So in your observation, you think you are not following mask and distancing in Vigo County? I thought every time I go places, everybody wearing masks. What can you attribute the increase? The only mandate we have is mask and social distancing.
Yeah.
If we're following that and we still have increase in rate,
From what we've
you think it's just because the season for flu, and
Well, from what we're
season for
seeing
corona.
in the contact tracing, when we have pocketed outbreaks, the folks that are having the pocketed outbreaks aren't distancing and aren't masking. Okay, and if I'm respecting what's going on and I go to Kroger, for instance, and I see a bunch of people wearing masks, or just as an example, and I go home, I think, oh, that's probably pretty good. All I need to do is find out one gathering one function that they're not. You know, you can walk into a Halloween party with 500 people running around with no masks on. You know, if you're not invited to that, or you don't stumble upon that, or that's not part of the group that you're running with, you never see that. But we see it as contract tracers. We see it because the sick people come out of it. And they all have these commonalities, so we're able to trace those things. And invariably, they're not masking and they're not distancing and they're not following mitigation strategies. So that's where we're getting into trouble for the most part. And the other part is when people sit at home, elderly, mom and dad, grandma and grandpa, somebody brings it to them. Nursing home patients, they never leave their room. Somebody brings it to them. A healthcare worker, a family member, someone who's assuming they have allergies and they're actually bringing obviously a deadly disease right to somebody's the tip of their nose. And once it's inoculated inside of a nursing home, inside of an assisted living facility, it spreads like wildfire. It's highly contagious. And those folks have no rescue from that. And the long-term care, they're doing the best that they can, but the reaction to it is they lock things down. They shut the doors and shut the windows and don't let people out of their rooms. Ultimately, what happens is those folks, they get sicker and they get sicker and they get sicker and they die. And they die in clusters. And we've seen that all throughout the state of Indiana. You know, approaching, sometimes it's even over 50% of deaths are in nursing homes. So nursing home age patients. So we're seeing that here too. We did not see that the first time around. Our nursing homes, our long-term care facilities stayed COVID-free. They are no longer COVID-free.
Yeah. Your experience now after so many years, the death rate is less, right, compared to April or March. That people who come to the hospital with the treatment available, antibody, remdesivir, steroids. Do you think you manage the death rate a little bit better than before?
3 weeks ago, I would have agreed with that and said the death rate is less. And I'll tell you that there's something percolating right now that we're seeing at both hospitals here. We're seeing it in Indianapolis and in Evansville and Tippecanoe County. We're seeing a more virulent outcome a lot of times right now in the last week and a half. And Jim, you're shaking your head. Everyone that we talk to, this thing has gotten really ornery all of a sudden. The death rate it's a metric as well. If you have 100 positive cases and 10 people die, it seems like a horrible number. If you have 1,000 positive cases and 10 people die, it's a lot less of a percentage. Yes, so it looks like, okay, that's a decent metric. The problem is 10 people died each time, and it's preventable. It's available than it ever has been. You can go to Regional, to Union, to CVS, to Walgreens, to Paris. I mean, you name it, there are places testing. There are doctors' offices testing. Now antigen testing is more available too. So your death rates per positive cases may go down. Your death rate per hospitalizations it is on the rise in the last 10 days across the state. You know, at my own hospital, and I can speak to it because I've been there every day, we have people on ventilators. I don't know if any of them are going to live, any that are on a ventilator. I hope they do, but the mortality rate for ventilated patients is extremely high. It's well over 90%. And we have more people vented now than we've had definitely since April.
So lockdown is not gonna help. I don't think it's mandated in Indiana, locking down, right?
What we know from the history of the world is that when you have a disease species, you isolate, you separate, you segregate in that species. If it doesn't have a vector to carry disease from one to another, meaning mosquitoes or sand fleas or whatever it is, if you can isolate the hosts, those hosts deal with the illness ultimately, and then the organism dies off, one way or the other. Either the patient dies or the host can overcome it. But if you continue to put humans together that are infected with uninfected people, it's going to continue to propagate. That's how mitigation works. That's how isolation works. That's how masking works. We do it with every communicable disease that we can think of. And it's really the only thing that we have going for us with this. These treatments that are out here right now, they're not the greatest treatments in the world. Remdesivir, I promise you, is not the answer, nor is plasma. You know, vaccines hold a lot of promise, but people have to take them. They have to be proven safe. They have to be proven efficacious as well. So we're still on the underside of this fight by a long stretch.
I start seeing patient in the office. You treat them, and then later on at the end of the day, say, "Oh, I had COVID in April." You know, it's amazing how much, and then a lot of kids come home and have COVID nowadays. You know, it's amazing the how it spread. Super spreader is one guy will spread to 50, not like flu. It's sometimes it's 1 to 1. You know, and that's a problem. So I think vaccine is still probably the answer. You know. Thank you.
You know, the vaccine part's going to be very complicated. It's not going to be simple. And as some of you may know, the vaccine that's out there now is a vaccine that's never been done before. This technology has never been used. This messenger RNA is a completely different, has nothing to do with any of the vaccines we've had over the last 50 years. So it's really interesting, complicated. And you know, the logistics of freezing, when they're talking Celsius, that's not Fahrenheit. Okay, that's, you touch and your finger falls off. I mean, that's how cold 100 below Celsius is. So the health department's going to have a huge responsibility in distribution. The other products may come out and not need to be as cold, maybe just refrigerator cold, but we're going to have to gear up for mass. You know, they talk about maybe we can open containers for 1 minute, get maybe 1,000 samples.
6-hour thaw.
Yeah. So the distribution part's going to be a huge, it'll have to involve everybody. It'll involve the military, I'm sure.
We've already had conversations, just did a conference call today with the 181st, the EMA, both hospitals.
It's gonna
Had
be a
one
huge-
yesterday also, so those conversations will continue to occur. We're looking at doing the phase 1A, which is doing healthcare providers. We're looking to get the vaccine delivered to both hospitals. They're looking at tentatively right after Thanksgiving. And so it's looking at establishing points of distribution at both facilities and being able to immunize the employees for the hospital workers here in Vigo County and also for other counties in District 7. So that's going to be our first, and then we'll look at, with also the reminder recall piece of the vaccine from Pfizer, which is different than the reminder recall for Moderna for the second dose. But it's just all those different challenges that we have to collectively work on to have the best laid plans.
And this is happening when? First week of December?
It's tentatively according to the State Department of Health, tentatively looking at the first delivery coming in after Thanksgiving, right after Thanksgiving.
Wow, that's pretty good.
But, you know, 2 injections probably.
Correct, it is for both.
And,
One 21 days apart, the other 28.
It's going to take a huge public relations campaign because people do a terrible job with influenza vaccine. We're at maybe 50 or 60% of people that agree to get influenza vaccination. So now we're going to give them a whole new vaccine that no one's ever seen before on the planet. And that's, you know, 300 million people to walk in the door and get it done. I'm going to be like some people say, when Dr. Fauci gets his, I'll get mine.
Yeah.
That's good. That's when I'll go for it. I'll be right behind him.
Okay.
Thank you, Dr. Lim, Dr. Drucken, for the conversation. We have any staff changes, Joni?
We did. We had a staff person leave us to pursue a new career after 23 years, and that was Travella Myers. And she took an awesome job working at Hearthside doing safety, quality management, which is something that she thought would make for a new, fresh chapter in her life. And Amanda Bales is now the environmental health supervisor. So, and she's also the deputy administrator. And then in her vacant position, we moved Brandy. Where's she at? Grazer. She just finished her second degree, and this last one was from St. Mary's, and we decided she was going to put it to good use. And then in her vacated spot, we moved Jessica Kiger, which was our part-time employee, into full-time, and that part-time's still vacant with everything going on, but just a little bit of switching around.
Very good use of resources, for sure.
Absolutely.
Very good. And congratulations all that moved around, and thank you for what you're doing. Joni is talking about the amendment of job descriptions.
Yeah, when we When we used to have our job descriptions that were established, and Rhonda, I think you can help me on this, probably back in 1997, we had a company that came in and did a review and created all of our job descriptions. And then they, put us into different categories based on those descriptions. And one of the things that was on the professional job descriptions, so those that needed a degree, it used to say on there what the degree was, and then it would say or equivalent experience. All right, because you could have somebody, let's say, with an environmental degree in environmental health, and they may have had 8 years of experience working as an environmentalist in another county, and we could still have hired them based on the fact that ours requires a BS and not an associate's, but based on their experience and their education, they would qualify. Well, when the new company came in 16 and redid the job descriptions, they took that off of everybody's job description of the descriptions that required a degree. And I would just like our board to consider adding that, and because that's something you can talk about between now and January. If that's something you want to move forward, but we think that it was a beneficial clause to the job description as far as the qualifications. Say, yes, but if you've got 20 years of experience doing this or X amount of years doing this, just any questions or any input.
Are you having trouble finding adequate candidates with having the degree set at BS only or without having
Well,
the
actually,
experience piece?
it's not that we don't find the adequate. We obviously the nurses, we have to have RNs,
Right.
no matter what. We can't go with anything lower than that.
Mhm.
Or, you know what but like with environmental, a candidate came to mind that when we wanted we're looking at Steve eventually. He's going to retire soon. My gosh, he's been here over 40 years. Okay, so. And then there are good candidates, and one in particular has an associate's degree, has proven themselves as an environmentalist in another county, plus has had administrative experience. And I would hate to miss out on a candidate like that in that situation without having that clause. Again, can't do it for the nurses, but just for the environmentalist, something I'd like you to consider.
Sounds like a good idea. We should consider that.
Thank you.
Okay, Joni, we have the 2021 meeting dates set for January 20th, April 21st, and July 21st and October 20th. Is that correct?
Yes,
Okay.
hopefully.
Hopefully we can stick with the schedule.
Absolutely.
Yes.
So what's going on January 20th?
Inauguration day?
Kind of a big day.
We're not sure.
It's going to be our meeting.
Yeah, well,
We're not sure. Our meeting will be the important thing, the inauguration will be the thing. So this just kind of caught my eye though.
nah.
Who's inauguration?
I don't know.
We'll have a post-inauguration meeting here at 5 p.m.
Good point, Dr.
Our
Carr.
own party.
Is there any other business we need to address, Joni?
No, I don't think so.
Okay. Do we need to express the old business for the 2021 budget that you have on for next?
I just wanted to give you an update of all of our budgets went through pretty much the way that we had wanted them to. A couple are going to have to be tweaked or taken back to council. But for the most part, very satisfying, I think, with what we need and what they appropriated.
Very good. Is there any questions from the board on that?
When you say tweaked, Joni, what do you mean?
One of the ways the Indiana Code is written regarding the local health trust fund, it says that the council shall appropriate all the funds to the health department, and that didn't happen. And what happens if they don't appropriate the whole amount, then we lose the amount. That's something that the state has made extremely clear to the council. It was just something very minor that was overlooked, and we'll take it back to have it corrected. So that stuff like that.
Thank you.
Very good. Is there any other old business we need to visit, Joni?
No.
Okay. Very good. If it's all right, we'll move on to the program updates. Ronnie?
Hello, everyone. So mainly what I've been doing during the whole pandemic. We have our COVID meetings every morning. And then, of course, we have a weekly JIT call on Wednesdays. I'm in charge of the social media post, replying to people, commenting back, taking complaints on there. I write PSAs, guidance, anything that we really need to put out to the media or public. And then, of course, media interviews are kind of my bread and butter right now. So lots of that stuff, all mostly COVID, still trying to mix in some like influenza and stuff like that, typical things that are going on, but mostly COVID. Do you guys have any questions about or anything that you want to see more of on our social media or anything like that?
I want to thank you for what an exceptional job you've done, because I
Thank
know
you.
you've done so much work, and I've seen those Facebook posts and the interesting things that people are putting on there, and you have
Yes.
done a very professional job of responding to it.
Thank you.
So
I
thank you.
appreciate that.
And it's 24/7. It isn't just while she's here, but it's stuff that hits us over the weekends or even in the evening, but it's always something.
Yeah, because when people have questions about quarantines and COVID things that I can answer, I feel bad like on a Friday night. That doesn't have to wait till Monday. You know, like I can answer it, get it done and over with. So, and we all pretty much are like that right now with COVID. Evenings, weekends, holidays.
Are we getting any official word from the state put out on the vaccine or early plans or?
Not really. I think everything's kind of just in the planning right now, so nothing really punted to the media yet. Yeah, just anytime you guys think of anything you want on social media or that's important, just shoot me an email and we'll get it up, okay?
Well, thank-
We don't want to forget influenza.
Right.
And, because I had a couple positives. We've had a few. It's
Yeah.
kind of interesting, they traditionally come after the holidays.
Right.
Yeah.
And so we see that spike after, same thing with RSV, when you see that for the holidays. We don't want to ignore that and make sure people, because it's a real important issue.
Yes.
And the higher dose vaccine also. So we don't want to forget that. This is probably the most important year to have flu.
Right.
Have the numbers for the normal flu been at what the level that you would expect them to be, or voluntarily people coming in, or has it been more of an elevated level?
Yeah, I mean, right now we're seeing some anecdotal, just kind of spikes here and there, but Indiana, the zone that we're in the country, we have the influenza-like illness kind of percentage. It's like 1.9%, which means pick any date. It can be March, it can be April, it can be August the 1st. We're allowed to have below this line, and it's on the flu tracker that the CDC puts out. So if we start inching up towards that influenza-like threshold, that's when we start saying, okay, here it comes type of thing. And traditionally, it is mapped out every year, and Dr. Turner will reiterate this as well. So, after the holidays, late December, early January, all the way through to February, we see that's our typical. So now we're just kind of cruising along. We're still at less than 1%, but we get a few little pockets. Indianapolis had a few. It's like, where did all this flu B come from? For 5 or 6 days, we'll just see them, because we are testing a lot of flu people in the offices and also in the ER. So we're just seeing them anecdotally pop up. What it means right now, it's probably a little too early to say.
See.
And
So-
speaking for our clinic, I know our employee flu shot days, they did exceptional this year. So it seems like people knew that flu was important this year along with the COVID. So they came. Really, we didn't have to try that hard. A lot of people came just for our employee flu shots. So good turnout for that.
Is it a county employee rule for you have to be vaccinated to work here?
No,
Yes, the
it's
hospitals are.
optional.
Hospitals are not optional.
And the COVID-19 vaccine will also be optional for hospital employees.
Thank you
Alright,
very much.
Thank you guys.
I had one question actually. You had mentioned the daily updates. Is
Mhm.
there a way that we could have like a Zoom link, or you guys could set up a Zoom link that we can log in anytime? Not that we have to log in every day, but I'm sure don't want to speak just for the whole board, but I mean, even myself, I would like to at least attend some of those meetings just to be informed and everything, but I can't just come over here and get to the meeting in person.
Right. Yeah, we definitely could set up something that you guys could call into and participate.
They're fascinating.
I'd have to do that.
It
I'm
gives
sorry.
you in a snapshot exactly what's going on in the county and in real time, and it's mind-boggling.
I'd have to agree with Brian. It'd be a great opportunity for us to step in and listen
Yes.
with that.
And you're always more than welcome to attend, and if you can't, we'll figure out a way where you can listen in.
Very good. Thank you very much. Okay, we'll move on to vitals.
Hello. We've been very busy with phone calls. We're still doing the mail with the birth and death certificates. We've even put a drop box in that they can go back in the back of the building and drop everything off. We go out there throughout the day, bring them out, process them, call them back in, or we can mail them. We're still doing the mail and everything. Brooke's been very busy with death, with the COVID and everything, but we're still trucking along.
Everyone still needs a birth and a death record.
Yep. Do you guys have any questions? Okay, thank you. You want to talk about it?
Yes.
Brooke's going to go ahead and give you guys an update. Hello.
So I was just gathering numbers today to let you guys know kind of what's going on with our numbers. So I have, for the month of October, we had 184 Vigo County deaths, and 25 of them were COVID. In the month of September, 137 deaths, and 16 of those were COVID. So this time last year, the numbers were 125 regular deaths for both months, October and September. And then August is about the same, 118 and 119. I started doing a little chart. So March was when COVID first started. We did 3 death certificates in March, 4 in April, 5 in May, 0 in June, 2 in July, 8 in August, 16 in September, 25 in October, and so far 17 already this month in November. We have 80 total COVID deaths since March, and like Dr. Brucken said earlier, I've also certified 39 non-resident death certificates as well. So.
You want to talk about out of one facility?
So out of one nursing home facility, from October 1st to November the 8th, they had a total of 22 deaths, whether it was in the facility or in a hospital or in hospice, and 17 of those were reported COVID positive.
One nursing.
Just
One
one
nursing
long-term
home.
care. So imagine all the long-term care, and then Jane's going to speak to long-term care
Did you
during her
guys-
presentation, and she's going to talk about all the places, the long-term care and how it's lit up.
So how did you guys mitigate the situation on those nursing homes?
That's what, Jane can answer that. She communicates with the state on a daily basis. Any other questions?
Would you be able to email those numbers to us that you had reported?
Would you want a copy of these numbers?
That would be great, yes.
Yeah,
Thank you.
absolutely.
Thank you.
Can I ask you questions? I'm just curious. When they die of COVID, do they get cremated or just regular?
Okay, that's a good question. So they do get cremated, they do get buried, of course, also. There was actually 6 coroner's cases that were COVID positive, and Beans Regional does not have an airtight facility. No autopsies were able to be performed here in our county.
So it's not mandatory that they need to be cremated?
No, there's no, you can still, whatever final wishes you want for your loved ones still. Absolutely.
So is there any cases of transmission from a dead body, Bracken?
No.
The virus die with the patient.
Yeah, and it's how people that have expired are handled as well. So they take precautions against things. So, you know, the virus itself obviously lives in the body. It has to be expelled from the body. So unless, you know, when you're doing an autopsy, I don't want to be grossing anybody out. So, but when you're cutting into lung tissue and that type of thing, you know, obviously the examiner would be wearing a proper PPE just in case type of thing. There was a case in Europe back in the first swing where they said one coroner in Italy probably died from COVID, probably from doing autopsies. So, but nothing here in the U.S. that I've ever seen.
Thank you.
Very good. Thank you very much. You want to do Vector or
Is it Vector
environmental?
next?
I'm sorry.
Or did I jump the gun? Nope, it's me.
Yes, you're speaking.
All
Sorry about
right.
I think he called you a vector.
Okay, so as environmentalists have been, we've been working on getting some of the restaurant inspections done, along with the swimming pools and the tattoo parlors. Our septics are still going strong, trying to wrap up the end of the year stuff before the weather gets bad. Beth, our secretary, has been working on getting the 2021 food permit applications mailed out. And we've also been working with the contact tracers. We've been doing contact tracing, answering phones, working on the governor's orders with events that are supposed to be happening in our community. With the governor's new directive that's came out, or order that's came out, he's just changed that from 250 to 50 people. So we've got a lot of events that we've got to go back and try to discourage them from having their event. I didn't know if Dr. Brecken wanted to talk about that.
Sure. With the newest executive orders, obviously clamping down on gathering sizes, and we know the importance of monitoring gathering sizes to try to help mitigate this issue and this largest, most recent surge. Like I said, we are identifying gatherings as being the number one place where this is spreading in the community, whether those are organized gatherings like fraternal organizations or churches or weddings or funerals. Whatever they are semi-organized or organized activities. House parties have also been in there. The colleges have struggled with house parties as well. We have the ability now as a department to look at plans from activities. If they're going to exceed 50 people, we have the ability to look at that with extreme amount of scrutiny. Personally, the governor's executive order clearly states if an event can be postponed or canceled, cancel or postpone that event. Meaning if you have a wedding that's been planned, that's understandable, but things like charity events and fundraisers and sports banquets, things that aren't essential to your way of life, they should be postponed or canceled completely during this time frame. We have that ability as a department to look at these things with a high level of scrutiny, and we intend to do so. In a matter just of public health, there's very little interest with me personally to be very lax with large events taking place moving forward. That is statewide. It is broken down by the color charts. Red counties, which we are not far from being a red county, they have their own set of guidelines as well. So we're going to be looking at that on a case-by-case basis, and we would certainly love the support from the entire board on that stance.
Can I ask you questions? I know what is the recommendation of our board? Somebody got exposed. Like say, I have a patient, I'm exposed, and the board contacted me that, hey, you are exposed. What do we verbally tell the guy who is exposed? You have to quarantine mandatory 14 days? Or do you need a test? Or you wait for me to have symptoms before I have a test? So if I see patients,
So,
how do you go? How do you go about it?
so when we find out that we have a positive and we do the contact tracing, we find out who their close contacts are.
Okay, and then what do you recommend?
So
to
with
do?
the close contacts, we go 14 days, either prior or 14 days from their last known exposure to the positive person. So they have to quarantine for 14 days
From the date.
from the last known exposure to the positive person.
Okay, say a week ago that person I was exposed to him, and then the test showed a week later that he was positive. My 14 days is counted from the date that I was exposed.
Correct.
So theoretically, I have 1 week left.
Correct.
Then I can
Correct.
be exposed again, other people. Okay.
Correct.
Now, do you require me to have a test if I have no symptoms?
We do not.
Can I have a test? So I said, if I'm COVID free in the test, that I can function.
No,
I still have to have
you
mandatory.
still have to do the mandatory 14 days.
Some people present their symptoms on the 13th or the 14th day. That's something that comes out of our contact tracing meetings.
Does people follow this? We
Quarantine
don't.
laws that are covered under Indiana code.
So what about industry's pushback? I know we've seen people who say, I can't go with my coworker, so, and I can't go back to work till I get a negative. I hear that all the time. That doesn't really fly, but they're still getting sent in by their employers on a daily basis and say, I can't go back to work, I have no symptoms, but.
And that happens.
Yeah.
And it happens.
Because I saw in the nursing home, they had exposure to a coworker, and they say, it's only a week. You say, oh, you can go back now because they don't have enough people to work, you know?
There are
No.
built-in exemptions for essential workers,
Yes.
healthcare providers. There's a whole separate set of guidelines for the essential workers right now, so.
But that means you are theoretically exposing other.
Realistically, they should be using the proper PPE. That's what this really comes down to. If you have the proper PPE on,
You
then
can
you
go to
shouldn't
work.
be exposing somebody.
So are you getting pushback from like the HR people of these industries?
No,
Oh,
No, not really.
they're being very cooperative. They
They're
don't.
sending their employees in, or they're doing it on their own.
Those are very rare occasions.
Say,
Because nobody wants to have their workforce wiped out with an outbreak.
sure,
You want continuity of operation, so you're gonna try to mitigate and keep it down to a minimum of your workforce that are out.
Yeah, I think speaking to your point, Jim, there's a lot of companies that ignore the CDC requirements where they say you don't have to have a negative test to return to, satisfy your quarantine. And there is no ability for us to talk to, Joe Smith's Plumbing to say, you can't make them get a test. They can do whatever they want because they're Joe Smith's Plumbing. Whether or not that tracks with CDC recommendations, though, they don't. But Joe Smith's Plumbing wants it done, so that's why they're sending their employees to get tested. Most times based on a false premise that a negative test means great things.
Any other questions?
And I hope there's not a Joe Smith's Plumbing like for real, so, yes.
Thank you very much. Next, we'll move on to vector control.
Hello, David, filling in for Mike. We're getting into our slow season, starting our vehicle and equipment maintenance. That's pretty much it. Any questions? Okay, thank you.
Thank you very much. Okay, we'll move on to contact tracing and a discussion with Chelsea
Chelsea and Jane.
and Jane.
Sure. Just tell them what's going on. Tell them about a typical day. What happens when you get up in the morning and what starts and then how it's pushed out.
Okay, so when I get up in the morning, well, I've got kids to get to school, but when I get to work, we start pulling numbers, cases that come through from the last pull of the day to when we get there in the morning. The constant thing, we usually pull all the time. It's a constant pulling.
Oh, constant.
We watch for new cases to come in. We get them from Horizon. Illinois usually faxes them. They come through MBS. They come through RedCap. There's multiple different places they fall through. Then we usually go into our 10 o'clock meeting. When we're done, cases go out and the tracers start working. And we work constantly. Sometimes we don't stop till 9, 10. I've taken phone calls at 1:30 in the morning. It's just a constant figuring out where things come from.
so where do you get your extra help?
We've got the tracers that we've hired, and that's, the
Is all that
environmentalists.
fund that you talked about, that's part of that?
Yes. We have tracers that are constantly working. Once they are assigned the case, they work it. because it could be an easy one to work, it could be, as I think Marcy once described best, as a spider web. So, especially especially once we left stage 5, and we saw everybody go and have great big parties and going out to bars, and you just, having events, it just exploded. And they're huge contact tracing situations.
Do you have enough people?
That depends on the day. Some days, yes, some days we need about 10 more. It depends on the amount of cases that come in and how fast we can get through them. If they are explosions or ones that we've had quarantined for a while because family is positive.
Would it be a part-time job for a college student?
We do. A lot of them are the ones that are doing their gap year, and then I have some that left in August to go back to school that'll come back Monday and start.
You get yelled at a lot?
That's this one.
We get yelled at.
Didn't I-
We're scammers. We're
You get,
scallywags.
Yeah. I've been reported to the police.
Yeah.
Yeah.
Those are crazy. That's-
I've had the
Yeah.
police called. I've had 911 called on.
So the actual COVID infected patients are the one telling you call all these people? Is that how you trace?
We get their information. We get information from them and also their employers. So we'll call the employer and get a list of people they've been around and trace the work side of it.
Which is exactly what we've been doing with all communicable diseases for the last how many years? We do it because we're HIPAA exempt, and the diseases that are deemed reportable by the state of Indiana in the time frame described, they all come to us so that we in real time see what's going on in our community, whether it's Hep A or tuberculosis or COVID, but all those come into us. But what we do in contact tracing, it's not a novel concept. We always have done it. Public health has always done it.
You put like a tabulated, this is COVID patient A, these are the contacts, and you figure out and call them back, hey, you ever get sick, or you only call them once? Like say, you got 10 patients, and I say, you guys are all potential,
Usually,
infection.
once
Do
we
you call them
quarantine
back,
them.
say whether they develop symptoms?
No,
at all?
usually after we've quarantined them, they keep our phone numbers, and if they start developing anything, we're getting phone calls. They want to know where to test, when to test, if this is a symptom. They
Do you get a
usually
lot
reach
of
back
call
out.
back? Do you have a
Mhm.
lot of callback on those?
Yeah.
Do we have any support programs for our contact tracers to deal with the verbal abuse they might receive? Like,
I've actually talked to Family Service Association
Okay.
because they have specific training on how to handle the stress
mhm.
that we're constantly under. Not just stress, but you also don't take into consideration, especially when you hire college students, and you see the look on their face when they find out that somebody that was their face has died,
Yeah.
and just all those things that go along with the whole COVID
Yeah,
response. It's
traumatization.
just very stressful. But I had talked with Jamie Wood about some type of program for the employees, including the contact tracer.
Okay.
Is this all a manual process that you do for this? Or is there any type of tool or app or anything that you could use that would help you do that more efficiently?
The ones that dump into MBS, I can pull on to an Excel sheet and sort through it that way. Most of it is manual. I keep my own Excel spreadsheet that everyone has access to. I break it down. If we link them to places, I think I've got 35 tabs across the bottom of places, either long-term care, parties.
Hotspots.
Mhm.
We just drop them into that.
Yeah, we'll say when the state took over contact tracing, they had an automated system. They would send an automated text and an automated email, and the response to that was paltry from people that were positive. They would see it on their phone as an 866 number and immediately delete it, type of thing. And then we never stopped here locally, even though the state said we got this. We never stopped doing it here because we had a feeling that it was going to fall flat on its face. And when it did, they said, "Go ahead, county, pick back up." And we had a nice laugh about that because we never let up on it. So everything is done manually just due to it's a taxing, grueling, thankless job, but they continue to do a wonderful job. If people on the other end of the phone would be forthcoming with information, honest, and just get through it, it would really, really help.
Understand.
Going to talk about long-term care? Thank you, Chelsea.
So Jane's been assigned as our long-term care.
And assisted
enthusiast.
living.
And assisted living, yes.
For those of you that don't know Jane, she retired as a public health nurse back in
1642.
2015.
we lured her out of retirement.
Yeah.
So I have had long-term care for probably about 6 months. It's kind of like started, I'll tell you the first facility that went up would be Meadows Manor East. We had probably 37 residents, 6 deaths total. That kind of went down because they burned all their employees out. So I get all employees because they test now twice a week. And all the long-term, and you're talking assisted living, that comes in by gobs. So they bring it in from the outside into the facilities. It's all the employees. It's not any, they're locked down. All of them can't have visitors at all. Signature Healthcare was probably number 2. It's still hot. It's probably got 37 positives at least, between 30 and 40. I don't have my pieces of paper with me. It changes every day. We've had 60 total employees at Signature, all positive. Total. That's a lot. And they've not gone on their second round of like, okay, are you out of the 3 months, quarantining? Right now, Meadows Manor North was another hot spot. They're 0, but they're using rapid antigen, which is not real good. PCR is better for testing. They say they're 0 now. Southwood has got 6. It was up to probably 70 residents positive at one time. They have 6 new ones. That's never going to go away. They just don't have a handle on it, but it's like goes up and down. Another one is Spring Hill Village. Right now they have 0, but they've had positive employees coming in. So it's just a matter of time. That's not being nice, but Cobblestone is another one. They've had their first second or third COVID red zone. They call it red zone because yellow zone is their quarantining before they come into the quarantining residents that have been around other residents. So they're at about 2. That's ticking up. And then Harrison Crossing is another one I see it moving up. The one that's scared me to death was Winmore. That's about 137 residents that live in there. They don't have anybody medical over that facility at all. It's all independent doctors. Each of them have their own. We flooded, they flooded Regional Hospital and Union there for a while. I had to call the strike team in 2 weeks ago because I had to get a hold of the United States Department of Health because they had no way of testing, but only with rapids, and they didn't have enough. They only had 2 nurses and about maybe 6 CNAs. They've all been positive, even the administrator. So they've got that under handle now. They quarantine them. I got the state in. I got them to come and test all of them, and they came back and they're totally. They had, I think in the 20s or 30s, they had positive residents, but they quarantined them. They've only have 7 left to finish their quarantining, and they're going to open. It scares me to open up the facility again at the 28th because it'll all be done. But that's just for outside agencies to come in, like home health care. They don't have anybody come out, but it's kind of weird. They can go out and go to the store or go out and go with their family to the doctor's office, but they can't come in, which I don't know. But anyway, so Winmore's kind of a hot tick still. Another one that I'm kind of worried about is, and this is all, you can get it off it's not anything confidential I'm telling anybody, but Sycamore Manor is another one, but they're doing better. They got control of it because they have outside testing that comes in, and they do PCR testing. So they've got it kind of, but it's just like a roller coaster. So almost every facility, but I think Westridge, Meadows Manor North, they're all kind of, I don't hear much from them, but they know I'm here. They all have my cell phone. Westminster Village Westminster is ticking up. It's like It's into independent living, it's into assisted living, and then it's also into the health center. But they've got a handle on it now. It's just taken a while to get it. They try not to overflow. They know not to overflow the hospitals because there's not much, but they have to, they have full code people, they have to send them. So, yeah. Yeah, Doreen Hoeneke and I have worked real close together because once these places start taking up, they don't have enough PPE, they don't have enough anything, so they're kind of desperate. So we kind of coordinate together and say, what do you need? Do you need the state there? I'll call the state on Saturday and they'll come. So the State Department House shows up. And they try to help them with infection control to hunker them all down and do what's right and stuff like that. And we try to find the source, and yeah, it's just crazy. But Doreen's great to work with. Thank you.
Any questions for Jane? You know, just a question in general, but you kind of touched on it too, but, you know, there's always been a challenge, how accurate is our testing? Whether it's antigen, PCR, I mean, you get numbers.
The antigen testing, and Dr. Brucken and I have talked about it many, many times. I don't like to see it used unless the person's symptomatic. I don't like to use it like that's a rapid. That's like fast. They have to be symptomatic. If they're not symptomatic, it's not going to be really a good tool to use. The PCR, which is the best, which is the swab they have to send off for 2 or 3 days, and then they get it back. That's more controlling. You can control it a little bit more when you have that kind of testing.
But I don't know if it's being used that.
Huh?
I don't think the rapid test is necessarily being used that.
Oh, yeah, it is, because the State Department of Health sent it all out to all these long-term care facilities. They all have it. They all have rapids.
Exactly, but they're testing all the employees, whether they have symptoms or not.
Right.
Some of them are, not all of them. Some of them are sending, like assisted living, they send them out to test. They don't test them in-house.
I wonder who's paying for all that.
Which one?
All of it. I wonder who really, what is the charge, and who's really, because if you're testing your employees twice a week and sending them out, and you've got 75 or 80 employees.
They're sending them to the free clinics. Most, they're, yeah.
For that or not, if the nursing home has to pay for it, that's a lot.
I don't think they're passing along the expense to the nursing homes. I've not heard that from the nursing homes
No.
anyway.
I think it's pretty much, there's some kind of funding from the state.
And the other challenge is when someone's positive, the employees, there's not enough people to work in nursing homes now.
No, what we do is, like, here, we talked about this before. If they have a COVID unit, they'll take those asymptomatic employees that tested positive with no symptoms, they'll work them on the COVID unit. They've actually worked symptomatic but they can't wear the PPE because they're too sick. So we try to coordinate it. I'll interview them and say, hey, are you asymptomatic? And they'll say, yes. You sure? And they said yes. So they'll call them and work them on the COVID unit.
Same with both hospitals.
Interesting.
Yep, they have to. They don't have any staff.
That's what I was going to say, they don't have enough horses to run the operation.
But they can't hardly work when they're
You still
sick.
have people there that's got broken hips.
Right. Right.
You know, I think it's important to point out too that nursing homes and long-term care facilities in general, whether that's LTACs or ECFs or assisted living facilities, they are not just these pocketed hotbeds of just infection, and they're full of people that are sick. They're doing the best job that they possibly can. Unfortunately, they are undermanned, they're understaffed.
Right.
They do not have the resources for when the place gets set on fire, basically. And we've got multiple cases, and these guys will tell you, Jane will tell you, you have 3 cases on Thursday. By next Tuesday, we've got 18.
Yeah.
And there's no way to extinguish that fire because it's already burning. So what Jane does and what everybody does collectively, we call in the state, we call in as much help, we bring as much education as we can. The state sends whatever type of testing they can get to them. Antigen, if you're actively infected and shed virus because you're coughing, you're sneezing,
Right.
and you're symptomatic, that's the antigen test, and it is rapid. Now, there are rapid versions of PCR as well.
Right.
You can get them back in 90 minutes, and you can have genetic material in your nose and not be symptomatic, but still test positive by PCR, which is polymerase chain reaction. So when we talk about rapid testing and PCR testing, there's a lot of finite details with that.
Mm-hmm.
And if you give people to do, and they all happen to be antigen testing, and they say, well, our best bet is just test everybody. If you're asymptomatic, you should be antigen negative. So what does that get you? It gets you a moment in time. That's all that it gets you.
The moment.
We're never going to pick up a pre-symptomatic person who's going to test positive the next day because they're not shedding enough antigen to mark the box off. So, but antigen testing is readily available. It's cheaper, it's quicker, and you have some sort of an answer. Antigen testing at some point in the near future, you know, this is where big business and industry will probably go. If you are sick at home, you're going to have an over-the-counter right off the Walmart shelf. I've got my COVID test. I didn't feel good. I spit in the cup and I put it on my pregnancy stick looking device and it says I don't have COVID. I can go to work. That's where antigen testing is going to be ultimately a great, great thing. People to attend ceremonies and to attend these things, they can do a rapid antigen test and be cleared for that particular time frame. Yes, Ted?
I got 2 questions. You said symptomatic. You're telling this patient the symptom if they have fever and cough, right?
Right.
If they lost their taste, diarrhea, that's very non-specific. Taste, yes, but do you only require, say, symptomatic when they have fever or they're spreading coughing? Or any other symptoms?
Any symptom that's on our list, and any symptom like congestion, cough, runny nose, diarrhea, any of those symptoms, they can have one and have COVID. They don't have to have all of them.
Let's say, you said your exposure, you get some symptoms, I test you, you're positive. They always tell me that, say, oh, they don't, after 14 days, I'm okay. I can go back to work. I don't need to be tested again. Is that how our protocol is? They don't need to be tested to be COVID-free before they go.
Right. They got to go 10 days from the symptom onset.
Yeah.
That's the infectious period. Then they should be able to go back. But
So
they have to be no fever at the 10th day.
So they don't have to be tested.
No. No.
Are you sure that they're not
Because
gonna
they'll still be positive. Sometimes they're positive for a long time after their test.
Correct.
So when do you require them to say, after they go through the process 10 days, you said you can go back to work? Is that you guys?
You pretty much mask up, tell them to social distance and watch
no,
their
They
symptoms.
don't have to be COVID-free on the testing, right?
Correct.
No.
We do not retest.
When does the COVID-free tests become negative in your experience, Dr. Bragg?
We've had people worldwide, there's reports well past 12 weeks still positive on the PCR,
So
on the
you
amplification.
do not test them. It's not required.
Correct. The infectivity, according to the CDC and the World Health Organization, the infectivity, your contagiousness ends after 10 days to a 99% certainty
From the date of infection.
from your onset of symptoms.
Symptoms, like when you got the cough.
Somebody asymptomatic, are they
Asymptomatic, you go from the test date, when they tested
if
positive.
somebody is asymptomatic, no cough, no fever, can they infect?
We believe so. Yes. Is it difficult to prove? Yes. Is it difficult to disprove? Yes. So it's that all boils down to contact tracing. That's the importance of it.
Yep.
And that's what we try to continue to work backwards and work deductively to figure out, did an asymptomatic person actually spread and infect? If you swab somebody and you took that swab around, do you have enough viral load to actively infect someone? We don't know. There's no way to test that to say with certainty, yes, you could. You know, if somebody sneezes onto a surface and we process it and it says, well, that's viral load, that could infect someone, sure. And is that sneeze, is that a symptom now? Is it not a symptom? You know, it's a sneeze. I sneeze all the time. I have allergies. So it's very, very difficult. And the people that report being asymptomatic, a lot of times are symptomatic and just don't know it. And that's the concern about flu season coming. I thought I had the flu. How many times have you guys heard? I thought I was just hungover. Lots. Allergies, and sinus infections, and bronchitis, and I'm a smoker, so I always have a cough.
A lot of people that I encounter when I talk to them say, well, 2 weeks lost income, you know, and they depend on that 2 weeks income, you know.
I tell them to sign up the Indiana Employment. There's a pandemic, COVID, they can file.
Oh, they can file it?
Mm-hmm. Yep.
They can get compensated
Mm-hmm.
for 2 weeks?
Mm-hmm.
Oh, I didn't know that.
And one of the things that Rhonda does is she prepares groceries for people that need them or things that they might need for their household. That's also covered with the CARES Act.
Good to know.
Thank you, Jane. Appreciate that, all that information. All right, since, Dr. Turner, you have anything
I just-
like that?
You give still enough, looking at the jail and prison numbers are pretty astounding. Give us a little feedback on what's kind of happening in the jail and for the prison.
Jail, we've been lucky.
Yes, yes.
For the jail, we have been extremely lucky. They've been hyper vigilant. Like kudos to jail commander Charlie Funk. But your federal prison, it was hot and then it cooled off and it's starting to pick back up again.
You know, theoretically, they're locked down. You know, I mean, how can they be getting?
You tell me how you think. It comes in from the outside, no different than the nursing homes or the hospitals. Yeah, the employees bring it in.
The county jail, I assume, is still overcrowded like it's always been. That's why we're building a new one, right?
Yeah.
Assume it's-
I'm assuming so.
Yeah, I know that they have quarantine areas set up for people that come in, you know, they keep them separate the best that they can, quarantine them. If anyone is not sick, then you can be exposed to others. They have an entire system, and Joni's right, they've done an outstanding job to date.
Any testing going on in the jail that you requires?
Do you know if there's any mass testing?
I
I
don't
believe
know.
so. Don't think so. I will say there's been other institutions in our state. If you look at some of the state-run facilities, the state prisons, horrible outbreaks and a horrible number of sickness and death. I won't mention them by name, but at one point, one facility had 3 times the number of positive cases that Vigo County had as an entire county, and inside of one jail. So inside of one prison. So when an outbreak gets hot, it takes off. And not every prison is built the same. Everyone thinks it's the jail cell, well, it's you and your jail, you know, your roommate. Not the case. They have dorms. There might be 60 or 70 offenders in one dorm, in a pod, exactly. So when that outbreak takes off, almost all of them are going to get sick. And then the guards handling them are going to get sick. And the guards shuttle around facility to facility as well. You might work in Plainfield one week, and then you have to transport a prisoner to Youngstown or wherever. And then now you're transporting, and then you stay there and work for 2 days. So it's a system that's wrought with problems, and unfortunately, you know, we've had lots and lots of positives through there.
You know, the federal prison population was older. I mean, there's people there in their 60s and 70s in the federal prison, there for life, as well as comorbidity. So it's not what the age is of the federal prison, but certainly higher than county. There's people.
Yeah, and the federal system, and Joni can probably speak to this better than I even, the federal system is, when you get put into the federal system, you go to a 2-week quarantine location. There are several throughout the country, and you're there, you're housed under quarantine until that they can show definitively you're not sick. Then you can be put into general population at a different federal facility or the same one that you're at. So there is a quarantining type of system, and that's probably the reason that they've done a good job. Until you inoculate that first quarantine system with someone who actually turns positive, then you have a cluster. Then you have to mitigate that cluster out, and that's easily explains kind of why they have a hot spot here, and then it cools back down, and then another hot spot, and it cools back down. It's I think they make do with the best that they can, considering the circumstance. Was that accurate?
Yes.
What's the latest in your treatment, Dr. Bracken? Still the same?
Yes and no. Remdesivir is the antiviral treatment, convalescent plasma, and actually is this being live streamed for people that are listening. There is a horrible shortage for convalescent plasma right now. We are waiting days and days and days to get people's blood type matched for plasma donors. So I contacted media tonight before I came in, begging people that have recovered from this, tested positive, to go and try to donate plasma, because the patients that are sick and those that are going to be sick need plasma like crazy. Plasma is just people's antibodies that have already fought through this. And it's a bit of a process, but you go and you give blood, and then they say, yes, you have antibodies, we want your plasma. And you can get set up on a plasma donation. I believe there's funds available for it as well, if I'm not mistaken, but we need plasma in the worst way. So plasma shortens somebody's hospitalization. The remdesivir is an antiviral, for lack of a better term. It just kicks it out of the replication cycle, so it shortens your course of the disease. What I tell patients every day is ultimately, though, the person's body has to fight this off. So we use steroids to help blunt the immune system, and we rely on the person's body and their own defense mechanisms because there is nothing else. There's nothing to kill it. There is no direct antiviral that says we're gonna knock this off and this will, there is no penicillin for your strep throat for this. So the body has to do it. That's why our older folks and our comorbid people that don't have the immunity and the defense mechanisms die from this, and they get so tragically sick from this. Most times, young people do a lot better, most times, but there's virulent strains. There's also levels of inoculation. Sometimes people get a huge viral load and they don't do well. Some people get a minimal viral load exposure. They do okay because their immune system can handle that much of a load. So there's a lot of variability to it. We use high doses of vitamin C and we use zinc. Okay, those are vitamins and minerals. So, think back. You can imagine going to the hospital and you're getting vitamins and minerals to fight off your infection, your life-threatening infection. That's what we're doing across the country because that's all we have to manage this with. There are monoclonal antibodies that everybody's reading about now. They are not for hospitalized patients. All of the things like hydroxychloroquine, everything that's been through there, they are not for the sick of the sick. So they're not really going to be beneficial to the general population when they get sick and hospitalized. So it's still a struggle.
The antibody that you get, the plasma, is just once.
It's 1 or 2 units. We used to do 2 units almost exclusively, but there's been such a shortage, we're down to 1 unit. And
Well, the Eli Lilly's monoclonal antibody, is that out already?
it's sort of out and sort of not, but that's an infusion for outpatient treatment. If you're hospitalized and on oxygen, you cannot get that treatment. You have to ask Eli Lilly. So it's the way that drug, and it's a 2-hour infusion, you have to be COVID positive but not that sick. So trying to figure out who gets it then. And so, well, let's stratify it for risk people. If you're over 65 and you're COVID positive, then you can get this. It's a 2-hour infusion. Where are you going to do a 2-hour infusion? Well, in a hospital. So you're going to take a COVID patient and put them in a hospital for 2 hours to run an infusion, and they're not even sick enough to be there. But now you've got healthcare workers who are already taxed beyond belief, and a system that's taxed beyond belief to say, well, let's take a nurse for a one-on-one for a 2-hour infusion for someone who's not even sick and hope that it works. I mean, it's.
I know Union just got 150 doses.
Mhm.
Yes.
Trying to figure out the logistics of going to the infusion center.
Yeah.
Nights, weekends.
I know.
So
It's a
not gonna be
logistical
simple.
nightmare. It is. It holds some promise. I mean, monoclonal antibody therapy and even immunotherapy, these things, they hold a lot of promise. And it's just putting them into logistical swing to see if they work.
So you give them an ER then, right? The monoclonal antibody?
Have you been to an ER lately? It's bad in there right now, so.
So you don't give the monoclonal in the ER, it's an outpatient only.
Yeah. Yeah, so we'll see. I mean, the science behind it, like I said, it holds a lot of promise, but so does vaccine, There is no magic bullet, unfortunately.
Citromax not being used.
No, it's just an antibiotic, so it doesn't help. So.
I think one of the other challenges, and some of you may have heard the term long hauler, not a disrespectful term, but like a truck driver's a long hauler. People who've had COVID and have symptoms that persist, they call themselves that. If you Google it, there's a support group. And now that we're getting enough months out, this is becoming a huge issue. And you probably have some friends, everybody knows somebody now that's had COVID. And you don't know anybody, you had it, okay. So some people get very lucky, like influenza, when it's over, it's over. But a large percentage of people, it's headache, it's fatigue, it's shortness of breath. And when you think about workman's comp or all those different issues, how do you quantify I've got a headache? How do you go to your HR and say, I've got body aches? I'm still fatigued, but my pulse ox is 92. I mean, it's opened up a whole, and there's a wide range of people who are suffering terribly long term. And it's not been around so long now that we have that data, but the long hauler thing is a real thing. And it could take you out of your job forever, but you can't quantify it. You don't have any way to go before a judge and say, I need disability because I have this crushing headache and body ache every day. So the long-term aspects that's one thing I think about the antibody test might prevent some long haulers theoretically. If somebody's not too sick yet, knock it quicker theoretically, and maybe prevent those who suffer long-term. with the long hauler, it's not a disrespectful term, it's their own term. It's a huge part of this disease that we don't have haven't wrapped ourselves around it very well yet, and how we're gonna manage it. But, it's a big part of this. It's gonna be part of our responsibility as a health department to help these people.
Yeah, and we certainly, it's not far enough into its infancy really to even establish long-term effects, even for pediatric cases and things. You know, we talk about myocarditis in these kids and teenagers and young adults, and is it going to be linked down the road to early dementia or whatever? I mean, who knows? We have no idea.
It'd be interesting to see if the flu vaccinations can render any partial immunity to it, So what do you think, Dr. Turner? Since you increase your antibody,
I doubt it, since it's a novel virus.
I know, but you increase your, your
I doubt
antibody
it'll get
to...
much.
Yeah, the neutralized,
I
yeah,
hope so, but I doubt if it will.
probably not. I wouldn't think. I mean, you have to have neutralizing antibodies to really fight something off, and the flu vaccine is, it's designed to rev up your neutralizing antibodies for the neuramidases. The H's and the N's, H1N1, H2, H3, all those types of things. So there are cross-reactivity. I read a study, there was 236 neutralizing antibodies already for COVID-19. The little kids have a ton of them. They have the most common one is in little kids' nose. They're not in old people's noses. They're not in adults' noses. It's like, well, is that going to be good enough? Well, if you look at the plasma studies, we say, well, that's the neutralizing antibody that we want. How do we rev it up? We don't know. Nobody knows.
So as far as vaccination, the one that confers long term is for Ebola, for SARS, polio, right? You don't need to be vaccinated on those things, And so it's amazing, the immune system, And we don't know about COVID, whether it's a yearly thing or it's a...
All right, well, thank you very much. Obviously, we won't have any citizens input this evening, Joni. And our next board meeting is the pivotal date of January 20th, 2021.
Anything else going on that day?
No, not at all. So do we have any motion for adjourning the meeting?
Actually, Jeff, I wanted to bring something up, if that's
Absolutely.
okay. I'm sure everybody knows about the video that came out, and I'm not here to attack anybody on that or anything, but I just wanted to make sure that maybe we avoid backlash like that in the future. A half hour after that video was posted on the refrigerated trucks, I had phone calls, all day that day, text messages, constantly since that day. This was actually the only day that I haven't had a Facebook message, a text message, or a phone call or an email about that. And so, again, not trying to attack anybody, but like, what can we do to help mitigate stuff like that in the future? To me, it seems like the health department kind of has a little bit of a black eye from some of the things like that. And so how do we help gain and regain the public's trust? Because that's what we absolutely need, is, especially as the health department, we need the public to be able to trust us. So I guess I'm bringing that out for really just discussion more than anything. And if there's a way to help you guys to be able to put those messages out, that's what I'm saying. So no finger pointing or anything like that, or attacking or anything, but just solution oriented moving forward.
Yeah, I think I appreciate that comment completely, Brian, and I would love to be on national TV every night just pleading for society to put their trust in the public health delivery system with us, because what is being pushed out there, everything is intended for informational purposes. And I know we have been openly criticized to be employing scare tactics, and we're trying to make things up and generate falsities. Everybody sitting in this room that generates this information, they are not falsities. They are nothing. They're not proposed as scare tactics. They are reality. The refrigerated trucks got a ton of publicity, when in reality, we have more dead bodies than we have places to put them. So we have to do something, and part of our preparedness program is those refrigerated trucks. Things went on with non-COVID related deaths where we had problems with carcass dead body storage. So that had to happen. Something like that had to happen. And when people started picking that up and sensationalizing that in the media, things took off and got out of hand unnecessarily. And for us, we're constantly in a recoil mode where we're saying that's not how that was intended. You know, when Brendan and Joni made their video, and even when I'm doing an interview, and when Ronnie's doing an interview, we're begging and pleading for people to please pay attention and wear a mask and wash their hands and stay away from people. Stop congregations. Stop preaching against masking and preaching against distancing, the things that are causing our community outbreak to be so high. But you can't keep going on TV all the time and just begging and pleading and begging and pleading. It's like your mom yelling at you. Eventually you just quit listening. And the COVID quarantine fatigue and the pandemic fatigue has never been higher. And we are right now living in a society of absolute divisiveness. People have picked a side. They're going to stick to it. There are conspiracy theorists out there. There are, oh, this is governmental. This is political. This is all going to go away. We need some sunshine. Everybody has continued to ignore the science of things and the facts of things. And I get it. We all understand it. It's not an easy fight to fight. And I promise you that this health department, to a person, is trying their damnedest to fight it. And we really wish, operationally, we had an opportunity to be able to loop everybody in and make decisions. I'm as guilty of it as anybody. I'm busy with other things all the time too, and not able to be here. I mean, Joni runs an incredibly tight ship. Every single one of these people sitting out here, and even the ones that aren't here, are doing absolutely everything they can.
Yeah, and I appreciate those comments, Dr. Brecken, and yeah, again, I'm not saying nobody's doing their job or anything like that, but just maybe the narrative or the messaging could be more of the, hey, this has been a plan of not only just a pandemic, but any mass casualty that happens, instead of just all of a sudden saying, this is what we have, and then that's all that the public got hooked and told. And so even personally, when I was getting those phone calls, I was always like, hey, Brian, did you know this was going on? I was like, I found out right when I saw the video. So, for us to be surprised about it too, it's kind of like, oh man, do these guys even know what they're doing? So, that's why I had asked to be able to have a link to be in on the daily meetings. Not that I can be there every day, but I'd love to be able to participate and be informed, on my end. So,
I did like 5 interviews the following day, explaining further about health insurance for part of our plan is how it's always been in place. And I mean, I searched on all the education and Facebook, and I could not find those articles to bring up they weren't fun. They didn't continue to post those ones. They just continued to go back to the original video and put their own headlines. But whereas there was, I did tons of interviews, and they weren't as good for them to show.
Right, and it is a grim reality that people didn't want to hear, but where you received a lot of feedback from it, we did too, with positive feedback, to thank us for letting people know, you heard what James was describing to you. You've heard what the hospitals are like. We are right on the cusp of this going super south. It's a grim reality. People don't want to hear it. The same day that it ran in the newspaper, if you get 2 stories over or 2 pages over, it talked about how Indiana was at an all-time death so far in COVID. Do we think that Vigo County is exempt from that? It's not exempt. It's a reality. Implementing our mass casualty. The hospitals are already ready for it. It's a reality. It's a reality.
Yeah, I agree with that. And I'm not attacking. I'm just saying maybe crafting the message a little bit better.
Yeah.
I have to deal with that all the time too.
And please know, if you are receiving, any of you, a lot of feedback on things that you feel that you want answers, know that you can always call us, you can come by, you can email us. We're always here to answer your question versus having to wait. Then, this is a fine
Thank you, Joni. Thank you, Dr. Brucken. Thanks, Brian.
Thanks, Brian.
Appreciate that discussion. Is there any other discussion we need to have before the meeting this evening? Do I have a motion to adjourn the meeting?
One quick thing, we won't reconvene until after the holidays, so please have a safe and happy holidays with your
Happy
family.
holidays for everyone. Meeting's adjourned. Thank you.
Thank you.
Thank you.